Hi, folks. Welcome to everybody, wherever you are. So today on our forum, Young India Intensivist, we have a very important topic, ventilator-induced lung injury. You know, one of the foremost job while ventilating a patient is not to cause injury. So that is a very important message that we'll be conveying today. And we have a very special speaker today from Mexico, Dr. Miguel Ibarra Estrada. So Dr. Miguel Estrada is a very promising intensivist and he's doing some wonderful work. So I will just make an introduction. He's an internal medicine and critical care physician at Hospital Civil Fray Antonio Alcalde, Mexico. He's also the adjunct professor of critical care program at University de Guadalajara. And apart from that, he has done some wonderful research work in recent times. He was part of the meta trial on awake proning in COVID, and he has published a very significant paper on methylene blue as a vasoconstrictor. And for this and for the lot of research work that he has done, he's been awarded a gold medal by the Society of Critical Medicine United States. And he's also a member of the National Investigative System Mexico. He's a member of the Latin American Intensive Care Network, LIVIN. He's a member of the International Group of Mechanical Ventilation, VVent, and International Awake Proning Positional Meta Group member also, like I just mentioned. So I'm sure we are looking forward to a wonderful 45 minutes, 1 hour, and it'll be nice to hear from him. And Dr. Ibarra, I thank you very much for sparing your time and taking your time out to educate all the young students in India and across the globe. Thank you so much, sir. Over to you.
Thank you. Thank you. I'm pretty honored for this invitation. We talk about the ventilator-induced lung injury. This Vili is nothing else than the same damage that the classic description of ARDS, the same patterns of inflammation, but this has a major drawback. This is a damage induced by us, but a major drawback is that we don't have a conceptual, a definition, a strict definition. You cannot take a list of criteria and say, well, this patient have this one, this one, this one. So the diagnosis of Vili is established. You cannot do that. We have few options to diagnose Vili. We have to assume that the patients with the better outcomes had less Vili, and the patient who died or with worse outcomes had a worse inflammation, worse pathologic process. So that's the first difficulty in when we talk about Vili. Just think about what happened in the ARMA trial. If you see the first day, the first 2 days in the group that received excessive tidal volume, well, those patients, if you see the graphic, those patients had a better oxygenation. So what happened there? Why does this patient apparently were okay? One should assume that those patients, that this excessive tidal volume, of course, help a little to increase recruitment. So the oxygenation is good. But this excessive volume along the time in the few next days led to more damage, so the benefit was lost. And this knowledge of the damage that we can do with a ventilator has increasingly become more fine-tuned. The first description is the barotrauma. This is very obvious. This is the most acute presentation of Vili, but there's a more subtle lesion we can induce. Is the volutrauma. We talk about in the few next slides about every one of these. Atelectrauma and ergotrauma. When we talk, we started to pay attention to the mechanical power. The barotrauma was first described by Macklin and Macklin. If you remember the Macklin effect in the tomography, well, those nice descriptions teach us how a rupture in the bronchiovascular sheath is the reason for the air introducing in other regions where should not be air, you know. And there's a microscopic description of this damage, which led eventually to barotrauma in the form of pneumothorax or mediastinal emphysema. If you remember in the 90s, for example, clinicians were used to see barotrauma even in very high rates. They were even used to put chest tubes in in a prophylactic fashion in patients with ARDS because they know there was a high possible probability of appearance of pneumothorax. And then Webb Tierney uh, give us this gift, this investigation, very interesting study in which they prove that the excessive pressure, yes, that's bad, and excessive pressure is bad, but they they give ventilation with lower tidal volumes despite excessive pressures, and they perform that by trapping the thorax and the abdomen of some animal models with some rubber bands, and that's how they limited the tidal volume. And despite an excessive pressure, they found that the damage to the lungs was decreased compared to those who were not in which tidal volume was not limited. And Dreyfus also studied this topic very interestingly. They also show that by limiting tidal volume, they also show that the models with tidal volume and high pressure, despite a high pressure, the models suffer. They had less long weight, less extravascular long weight compared to the other models, and they had lower albumin in the interstitial phase of the lung. So this pulmonary edema, due to high pressure, was avoided by limiting the tidal volume. This is again, I want to stress this. This is a more subtle damage. You cannot see it immediately. The damage induced by volume, by excessive volume. Interestingly, they also found that the application of PEEP was at certain point was also protective to the appearance of this pulmonary edema. And the next is atelectrauma. Slotsky, the team of Slotsky have shown us for decades how this effect of opening and reopening and closing of alveoli could be also detrimental. There's no a, a, a lung region that is collapsed is not that bad. If you open and if you allow that the alveoli open and close repeatedly, that's worse. You know, there's more inflammation there. There's more injury in those regions that are receiving insufficient level of PEEP, as shown in this experiment. If you can see how the models that receive a higher PEEP, their injury was similar to those in control with a protective ventilation. And this is very interesting because the biotrauma is the reflection of how this process that we initiate mechanically becomes a systemic trouble. You can see how the tumor necrosis factor and many other markers of inflammation in this study. By the way, this study is in human patients. You can see how in control patients with non-protective ventilation, the markers increase it, and in patients with lung protective strategy, these markers, on the contrary, it decreased. But the interesting of this study is this is not only happened in the lungs, this happened also in the plasma at systemic level. The trend was the same, an increase of these markers in the non-protective ventilation and a decrease in those who were ventilated with a protective strategy. And I think this is very, very interesting study. You can see how this increase in inflammatory markers it could be reversible. This in these patients, this team showed us how a low PEEP with high tidal volume, that means a non-protective strategy, increased, as expected, increased the inflammatory markers with several cytokines. But when they restarted a long protective strategy, these markers within an hour, kind of an hour, the markers lowered again. So you should think always that you should always should looking for any mechanism of ventilator lung injury, ventilator-induced lung injury. You should not wait to see the barotrauma, which is the final end of this damage. You should seek for the more subtle damage. You can see how it's not only an increase in certain markers in serum, it indeed had effect in other organs. You can see how not only in lung, the apoptosis is increased in the parenchyma of the lung, but it also in the kidney, in those ventilated by an injurious strategy, and also in the intestinal villi. Look at this regression, how the patients with injurious ventilation had also an increase in plasma creatinine. You know, this damage, if you allow this damage to be persistent, it becomes not so subtle. So these four types of damage, this distinction of barotrauma, volutrauma, atelectrauma, it's more a distinction for educational purposes, but these are always happening at the same time if you allow it, and becomes a systemic trouble. So you must be always aware in which circumstances the damage occurs. You know, and there are three circumstances, the three main drivers of this damage. The more obvious, an excessive pressure, ideally assessed by transpulmonary pressure. Another relatively easy to identify the collapse of alveoli. But the more subtle damage is this, the stretch, the tidal stretch. This is the strain. Strain is the damage induced by the change in the size of the alveoli. And if you give an unnecessary large tidal volume, you can induce also damage just by the changing size of the alveoli, not necessarily reaching an excessive pressure or an excessive collapse. This intermediate phase is very dangerous, especially because it is most difficult to detect. You cannot talk about ventilator-induced lung injury without referring to the ARMA trial. We all know that low tidal volume is the cornerstone of protective ventilation. A very nice necessary number to treat of 11. That's very good. But some may may say that this is pretty obvious. Almost 20. This has been more than 20 years that we know that tidal volume is good, but some might say that this is too obvious. There's no need to repeat this to keep talking about low tidal volume, but it is because we're not really doing right because this low tidal volume approach is not being applied in the real world. It's not being applied as should be. Just around 60% of the patients are receiving a lung protective strategy with a volume of less than 8 milliliters per kilo. Many patients are still receiving. Look at the year of this publication is from this year. Yeah, the clinicians, we don't know why, but clinicians, not all clinicians are applying this lung protective strategy. Why? We don't know. Let me look at this. This is a real life example. This in Mexico. This is a real medical record of an intensivist in a third level center in my country, and I already translated the important points to you. This is a patient with ARDS and a little bit of obstruction, but this is a female patient of 155 centimeters of height, which is a predicted body weight of 48 kilos. And this guy, this intensive, this physician, say in his notes, in the medical record, that the current tidal volume is this one, more than 900 milliliters, which is 19 milliliters per kilo per predicted body weight. We all know, I hope that we all know that this is obviously excessive. This is obviously injurious ventilation. And what else? This intensivist also say that his treatment plan is increasing inspiratory pressure to improve tidal volume. I don't know what what did he mean with improved tidal volume, but it's obvious. Obviously, he doesn't know that he's damaging this patient. But we know that a low tidal volume is good, okay? But you should know that the benefit identified for these low tidal volumes is only observable if you compare this low tidal volume, 6 milliliters per kilo, if you compare against a very high tidal volume. In many meta-analysis, this has been shown that the significant difference has only been found when you compare 6 milliliters against more than 10 milliliters, 12, 15 milliliters per kilo. You must know that there's no significant difference in the benefit if you compare 6 versus 7, 6 versus 8, 6 versus 9. So what does this mean? This means that you must forget about uh, this approach of one size fits all. Just you must know that not all patients with a diagnosis of ARDS are suffering with the same magnitude. The disease is not equally severe. You know, look at this. Look at how a one-size-fits-all approach with 6 milliliters per kilo and a plateau pressure under 30 could still be detrimental for many patients. For up to 30% of patients, these patients might suffer from overdistension or hyperinflation. Look at it. This is a patient ventilated with a more protective approach. This is with a lower plateau pressure. Both patients have a protective level of plateau pressure, but if you look at the patient with more protective strategy, as assessed by CT scan, you can see how most of the parenchyma has a normal aeration. This is assessed by the level of Hounsfield unit in the CT. This is an objective method to assess aeration. This is in fact the gold standard for assessing lung aeration. But if you look at the patient, which is supposed to also be also being ventilated with a protective strategy, but a little bit higher plateau pressure, is suffering for a very high proportion of overinflation in many areas who were already inflated. Oh, and obviously more regions with non-aerated alveoli. So what this tells us that you cannot apply the same dose of tidal volume and the same goal of plateau pressure. That not guarantees you that the patient is not suffering from ventilator-induced lung injury. Look at this. This is a regression. It can show all these patients. You can see how all these patients who had a protective and a legally protective level of plateau pressure, they are suffering from tidal hyperinflation. And not only a hyperinflation, of course, they are suffering also by an increase of inflammatory markers, significant increase compared with the patients with a more protective strategy. And we know tidal volume is good. We know that plateau pressure must be maintained under 30 centimeters of water, but we must also know that even with a long protective level of plateau pressure, the less the plateau pressure, also the mortality is different if you use a protective lung strategy, a low tidal volume. This difference in mortality in low tidal volumes is also observable even if the plateau pressure is not high. So you should always aim for the lowest plateau pressure as possible. Look how these patients with this is a very interesting study by Giacomo Bellani that shows that those patients with a higher plateau pressure had an exponential increase in metabolic activity, in inflammation, in a greater inflammatory pattern in those patients with had a plateau pressure above 26 centimeters of water. So you should not you should be aware that even a plateau pressure lower than 30 might still be injurious for the patient. And this is a very illustrative study. This is a systematic review and meta-analysis by the team of Wolliger, Amato. They showed us that this low tidal volume strategy, okay, is good, but the benefit is only significant in those patients with a high elastance. Those patients with the most severe disease. For those patients is the most benefit by a low tidal volume. They perform this interesting directed acyclic diagram where they show us how the elastance also has a direct effect in the outcome of mortality uh, in a opposite direction of the low tidal volume, because the elastance, according to the elastance, the low tidal volume might or might not be beneficial according to the producing to the promoting of lung stress and ventilator induced lung injury. And this is another very interesting sub-analysis. This is a sub-analysis of the original study, the ARMA trial. This is more than 2,000 patients that were not included in the original study in the ARMA. They were excluded by other non-medical reasons, unable to consent, the physicians refused to enroll the patients, they had more than 36 hours, but those patients had the same clinical status that the patients that indeed were included in the study. In this sub-analysis, they found that the patient, this is as expected, they found that the mortality increased in the patient with a lower compliance whose tidal volume was raised. We all know that. If you increase tidal volume in a patient with low compliance, well, the mortality might be worse. But what happened, look at this, what happened with the patients whose compliance was higher, near to normal, but with a diagnosis of ARDS? In those patients, the tidal volume, if the tidal volume was raised, the mortality decreased. Well, this image, this interesting sub-analysis shows how 6 milliliters per kilo might not be the best strategy for all patients. Of course, might be the best strategy for many patients, but not for all patients. Remember that keeping a low plateau pressure at the expense of a low tidal volume, keeping plateau pressure less than 30 centimeters of water, an increase in plateau pressure is associated to increased mortality, but only in those patients with a driving pressure over 15 milliliters per kilo. Look at this. These patients had a high plateau pressure, but a low or near normal driving pressure. Their mortality was not different to the patients with low plateau pressure and low driving pressure. So you should think that plateau pressure, this single number of plateau pressure, is not necessarily the most important factor in lung protection. What is the most important factor? What is the factor that really damaged the lung parenchyma? Think about these two patients. Think about the two different patients. Both are men, uh, but their pattern of consolidation is different. Why on earth you should think that 6 milliliters per kilo for both patients with the same height, why administering the same dose of tidal volume, why will be equally, do you think it will be equally beneficial? Of course not. 6 milliliters per kilo might easily overdistend this, this area and might be beneficial in these patients. But it could also induce this low tidal volume. It could also induce more collapse. Even if you use a significant amount of PEEP, a low tidal volume is also associated to a more alveolar collapse. So why should this patient might receive the exact same dose of tidal volume? That's that does not make sense, right? The real factor that stretches the alveoli and damage the alveoli is the strain. And the strain is the excessive tidal volume that you administer to a patient according to their functional residual capacity. This is the real size of the available lung to be ventilated. A strain shouldn't excess shouldn't exceed a 1.5. If you exceed, ideally it should be 1. The same amount of tidal volume to the same amount of available lung to be ventilated. So this is the ideal, the ideal, the ideal ventilation, same tidal volume to the same size of the lung. We cannot measure directly a size of the lung at the bedside. Like Gattinoni, if you can take a CT scan every 5 minutes and every change in the ventilator, that's okay. But most of us cannot do that. What can do? We end expiratory lung volume can be measured by tomography, by gas dilution methods. It's really difficult at the bedside, but we do know that the amount of lung inflated is linearly correlated, a good correlation, with the static compliance. So compliance is a good surrogate of the size of the lung to be ventilated, available for ventilation. So we could make this dosification of volume according to compliance. How do we calculate compliance? Compliance is the difference, the delta, the difference in volume divided by the difference in pressure. So this is a simple procedure of math, and so if we calculate this, it also we just cancellate these two, and we have this one. What is this one? This is the driving pressure. This is the reason, because this is the reason of why driving pressure is very informative about the size of the lung, and according to the it's a very good target for addressing how volume you should administer to the patient. This is this is why the driving pressure has a very strong physiological rationale, you know. Uh, and talking about driving pressure, we uh, most people love this image in the original study by Amato in New England Journal, but I think this is the favorite image for most people because it shows how the mortality increased with a higher driving pressure. But my favorite image is this one, is the image 2. This image shows you the pattern of the response to the different change in settings where, in a try to manipulate that driving pressure or PEEP or plateau. Look at this third column. In this third column, the airway pressure is increasingly is increasing, progressively increasing according to an increase in tidal volume, but with a similar PEEP level, 11 PEEP. If you increase tidal volume, you might get an increase, a proportional increase in plateau pressure. And as the plateau pressure increases, also the risk of mortality increases, okay? Look at this one. If you maintain the same plateau pressure, in order, thinking that the plateau pressure is the most important variable, if you have certain level of PEEP with the same plateau pressure and increase the PEEP, but the plateau pressure keeps the same, what does this mean? This means that this increasing PEEP is reducing driving pressure, and it also means that you are really recruiting new alveolar units and lowering the process of lung injury. So the mortality progressively also decreases, increasing PEEP, but maintaining the same plateau pressure. Now, what happened in those patients in which you increase people in order to improve wherever target you have, let's say oxygenation. If the hemodynamic status allows you, you increase PEEP, and you also see a progressive increase in plateau pressure. But if the driving pressure stays the same, this is not necessarily bad. If you can see how, despite this progressive increase in PEEP and progressive increase in plateau pressure, the mortality is the same. Why? Well, because driving pressure was kept at the same level. No, this is the reason, this is the rationale why the driving pressure is a way better strategy, a way better target to scale the tidal volume in any patient with ARDS. This is you're titrating the tidal volume to the compliance, to the available lung region for ventilation without inducing excessive lung injury. And look at this example. In this example, you can see how a driving pressure of 18, damaging airway pressure, you obtain that with a zero PEEP. Zero PEEP and a safe plateau pressure. This is not necessarily good because you have a driving pressure of 18. Then you increase PEEP in order to improve recruitment, and plateau pressure is still good, under 30, but driving pressure is still high. This means that some areas are still being subjected to overdistension. You increase the PEEP even more, 12. 12 out, and the plateau pressure is still in safe level. Now you have a driving pressure, an acceptable level of driving pressure. You're good. You might even want more recruitment and increase more the PEEP. If the plateau pressure keeps is maintained under 30, well, you might say it's okay, and the driving pressure is the same. So, but your approach, you're getting closer to a non-safe level of plateau pressure. So take care. This is good, but take care. If you keep increasing PEEP, you're gonna reach some point in which driving pressure is higher again, and the plateau pressure is over safe levels. So this means that you started to promote more overdistension than recruitment. So from here, you have two options. You can reduce again the PEEP, or you can reduce tidal volume. If you reduce tidal volume, you might potentially obtain again a good driving pressure and a still safe level of plateau pressure. Okay, these patterns, this response is just an example of what we just see in the study by Amato. I hope this helps to understand better these interesting results of the study by Amato. So I'm not here to tell you what is the most adequate PEEP strategy. We know that you should avoid the recruitment and reopening of alveoli. This is another wide topic. I'm not gonna tell you what the best strategy for PEEP, but you should always aim for the most adequate PEEP, and not PEEP to maintain recruitment without excessive transpulmonary pressure. And a very promising strategy to assess which patients might benefit the most for a higher PEEP is the recruitment to inflation ratio. This basically assess compared the compliance of the newly recruited lung with the compliance of the previously already open lung. When you divide those, you obtain this ratio, in a ratio of over 0.5 means that patients have a very high potential for a good response to increasing PEEP. It's just another strategy, one of the newest strategies. A couple of studies are ongoing, which we hope they show us if this is really helpful or not. I've applied this strategy at the bedside. It's a really cool strategy. It's really easy with a single maneuver of a single exhalation. Just keep in mind that this is another very good option to titrate adequately the level of PEEP and avoid the recruitment. This strategy have many decades since it was published. Remember the stress index, a very promising strategy to titrate tidal volume. You can analyze the ascending portion of the pressure time curve in a patient ventilated with volume control ventilation, and you could diagnose if a patient is receiving an excessive tidal volume, which induces overdistension or if the patient is receiving a too low volume, which is inducing the recruitment of the alveoli. You can see how in this very interesting study, they guided the tidal volume, titrated the tidal volume according to the stress index to obtain a normal stress index, and this titration allowed them to give a little bit extra tidal volume, around 7 milliliters per kilo, while maintaining the same plateau pressure, the same driving pressure, a little lower respiratory rate, a lower PCO2, a more normal level of pH. The patients were the prognosis was the same, but they were receiving a little bit more extra tidal volume. So this is another option for personalization of tidal volume. Again, I want to stress that you should forget about this one size fits all. 6 milliliters per kilo is not for all patients. And there are many studies, interesting studies with this technology, which we don't have, but it's a very interesting technology when they show us that inflammation, always inflammation is higher in those regions that are more collapsed. And if you know that this region, these dorsal lung regions are more collapsed, well, obviously it's expected that if you apply the prompt positioning strategy, also the inflammation is decreased. Yeah. So in other words, prompt positioning is another tool, another strategy, non-ventilatory strategy to reduce Vili, clearly reduces Vili. By homogenizing the gas to tissue ratio, you might see, you can see how this patient, how the non-aerated regions are more evenly distributed along the vertebral axis, the sternovertebral axis, and look at this over aerated regions are also decreased in these regions. See, when you apply prompt positioning, you should always keep in mind that prompt positioning is a very good strategy to reduce ventilator-induced lung injury. Some other suggested strategies those have not really demonstrated any clear benefit in outcomes, but are suggested by many experts. One of those is APRV in the TCAP protocol. The beauty of APRV is that you manipulate this equation of driving pressure, this relation of tidal volume, compliance, and driving pressure it is treated differently. With APRV, you directly titrate the driving pressure according to the tidal volume with the evolving levels of compliance. So you titrate directly the driving pressure. Others suggest you can see in real time how the lung is being inflated, what regions are, what percentage of lung are being overinflated, what are being de-recruited. But this method is not widely available, similar to the esophageal pressure, which is ideally you should assess the maximal stress of the lungs with considering the chest, the effect of the chest on the lung mechanics. But remember the EpiVent studies, EpiVent 1, EpiVent 2, which show no really benefit in outcomes, in clinical outcomes, in patient-centered outcomes. And mechanical power, I'm not really a big fan of mechanical power, but it's very important that you keep in mind that you could manipulate any of the variables that are included in the mechanical power calculation, but you must be aware that if you increase one of those, you should lower any other to keep an ISO power. If you increase PEEP, but the plateau pressure doesn't decreases, that's not good, right? This I like this image because this helps you to understand this close relation that have all these variables. If you increase respiratory rate, you should be ready to decrease that being PEEP, driving pressure, or tidal volume, whatever you could decrease. But if you increase one of those, you should decrease one of the others. And just to finish, a side note, this is touching the topic of PCILI, patient self-induced lung injury. This is a different topic, a different wide topic, but it's important this to talk about it because you might have patients still with a high dose of sedation, neuromuscular blocking, and the patients might still have double trigger related to reverse trigger. You should know that reverse trigger, this is the more injurious patient ventilator discordance in the patients still in the face of lung protection. You should avoid at all costs this patient ventilator uh, discordance. This is very dangerous discordance because it's associated with a tidal volume with next to 15 milliliters per kilo. You might set the tidal volume at 6 milliliters per kilo, but if you allow this patient ventilator discordance, that's not protective at all. At all. Look at the transpulmonary pressure. Very excessive transpulmonary pressure, just by the appearance of reverse trigger. And the last point, actively avoiding Vili is a time-sensitive issue. We already said this is difficult to diagnose. We cannot, we don't have a list of criteria to diagnose Vili on time. Unfortunately, Vili is a diagnosis, it's a retrospective diagnosis. When you see the damage, you say, oh, that was Vili. What did I do? Why there's Vili? And this is a time-sensitive issue because in every of these steps, there's a difference of less than 4 hours. The appearance of new consolidations is very, very fast if you are ventilating with an injurious strategy. look at the trend. In less than a day, the appearance of inhomogeneity of the lungs is increased exponentially. So it's very dangerous if you're not aware that of every variable that could induce a lung injury. So as a summary, you should always remember the three phases, the three circumstances on which damage is promoted by you, by the mechanical ventilation. And I want to stress look at how the driving pressure could help you in every one of these circumstances. This is the reason driving pressure is maybe the most promising strategy to avoid ventilator-induced lung injury. I'm aware of a large study, ongoing study, that is comparing, finally, it's comparing a strategy by titration of tidal volume, control group 6 milliliters per kilo, compared to a titration directly by tidal volume. We hope these interesting results of this study. Thank you.
Thanks, Dr. Ibarra. Wonderful presentation, lots of details, and I'm sure all the intensivists, students, fellows would have found it very useful. So, guys, if you have any questions, please put them up. We'll be happy to answer. So far there are no questions, Dr. Ibarra. So maybe I can just put up a couple of points for you to discuss for all the audience. So, Dr. Ibarra, considering villi, is there any evidence that the newer modes are helpful?
Sorry, can you repeat the question?
So for villi, ventilator-induced lung injury, do we have any evidence in terms of the newer modes of ventilation? Are they any better than the normal VCV or PCV that we use?
Sorry, my connection is failing.
You can't
If
hear
you
me?
could,
Can you hear me?
I can't hear you.
You can't hear me.
Could you write your question?
Yeah, I will wait. No problem. I will wait.
Can you hear me?
I can hear you, but can you hear me?
I hear you. I hear you now.
You hear me?
Yes.
Okay. So I'll just put up a couple of points for discussion for you to answer, and the audience might find it useful. So, Dr. Ibarra, regarding the newer modes, we have some newer modes of ventilation. Are they any better in terms of reducing villi as compared to the usual modes that we use, VCV or PCV?
You mean ventilatory modes?
Yes, ventilatory modes. Any evidence to suggest that they are better in terms of reducing villi?
There's a very interesting meta-analysis from 2015 in chest. They compared many variables and outcomes between modes of ventilation, pressure and volume. They only found a significant difference, and it was the work of breathing was worse in the patients ventilated with volume control. But otherwise, they didn't find no difference in any other outcome. You should think, for example, regarding one of my last slide, if you cannot avoid, we should be realistic. There are some centers in which it happened to me before, when we don't have available neuromuscular blockade, or we run out of propofol, for example, and we cannot optimize sedation or neuromuscular blocking of the patient. If you cannot avoid the double trigger associated to reverse trigger, what mode is most dangerous, volume or pressure? Well, of course, in that scenario, the volume control is worse because if you cannot avoid double trigger, the tidal volume will be twice. And if you are managing, this is a strategy I sometimes I have used that strategy, changing to control pressure. Because if you have a scenario where you cannot avoid a double trigger, well, at least in the double trigger, the tidal volume will not be twice. You know, that's the only scenario that I can think that the mode may be a difference. Otherwise, there's no reason to use any or other mode.
Okay, thank you so much, Dr. Ibarra. So then you touched about, the time course of villi in your last couple of slides. So one practical question would be, you have villi setting in while you are ventilating ARDS, and sometimes you get VAP also, ventilator associated pneumonia. So how would you differentiate? Sometimes whether the deterioration is occurring because of villi or VAP is setting in at the bedside.
It's really impossible, but you should only pay attention to the trends. To the trends. Another drawback in ventilator induced lung injury is the lack of recording of variables in the clinical studies and in the real life. If you remember the lung tape study, only 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 in half of the patients the plateau pressure was recorded. So how can you differentiate? How can you distinguish if there's pneumonia or no, or if there's sometimes the presence of pneumonia might not be relevant. The relevance relies in the response to your adjustments in the ventilator. But how could you assess the response if you do not record the changes? In our unit, we have a log sheet, so you can track every change and every response that you made for the patient. But your question is that I think it's impossible to distinguish.
Thank you. Thank you, Dr. Bara, for the answer. So another point would be, you mentioned about overdistension and collapse, and you also mentioned Dr. Brosha, Lauren Brosha's study on lung inflation ratio. So Dr. Brosha had taken a session for us on PEEP, and he had mentioned that we do not know whether overdistension is more harmful or atelectatrauma is more harmful, right? So we are at a stage where we don't know which is more harmful, over distension or under distension or collapse. So you want to make any comments on that? Like you have been reviewing and everything. You want to tell us anything about that?
That 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 strategy is in a very early phase in research because their protocol they have an ongoing study assessing also that strategy, the recruitment to inflation radio. And a disadvantage is that they with this variable only helps you to identify in a dichotomic way to establish if a patient is recruitable or not. But it doesn't help you at all to select the adequate level of PEEP. In their studies that they are in their protocols, they are using this variable to establish recruitability. And if the patients have recruitability, they use the highest PEEP possible. But we already saw that might not be the better strategy. Highest speed possible, avoiding a very high plateau pressure. But we already know that even a plateau pressure of 27 might be injurious. So this recruitment to inflation radio only tells you, okay, this patient, it only tells you that it worth the shot to increase a little bit the peak, but doesn't tell you anymore. So you should use it only as an additional test to know if a patient might respond to PEEP or not. You should never base your strategy of ventilation in this is a very cool strategy. I like it, but you should not rely your decisions on this single measure.
Thank you, Dr. Ibarra. Just last point, Dr. Ibarra, for everybody. This is a very practical thing. You know, we have a lot of patients. Everybody gets COPD patients, right? And they get ARDS. You have to ventilate them. And COPD patients often have bulla, etc. They have bulla, and we know one of the forerunners of pneumothorax is a bulla formation in ARDS, right? Especially when they go into weeks of ventilation. So any particular things you want to say about COPD, ARDS ventilation in terms of preventing pneumothorax, or what is the data, etc.? Should we be more careful? Anything you want to say?
The literature in for managing COPD is quite scarce. It's really there are not many solid data to give some guidelines on ventilation, but the classic idea is that you could use higher tidal volume with lower peak, but all the experts, I have talked with many experts, and the approach is the same. It's the same as with the patients without COPD. Many clinicians like to use more esophageal pressure, for example. So you can make sure that the maximal stress applied, which is also the static strain, maximal stress applied in the lung is still within safe ranges if you use esophageal pressure monitorization, because in a patient with COPD, you might have a plateau pressure, especially peak pressures, that is apparently high, but probably the transpulmonary pressure is not really high. Also, all the energy dissipates in the airways. So for you to really induce alveolar rupture of the parenchyma of the lung, you really need excessive transpulmonary pressure. Neil McIntyre have studied this, and he found that the real transpulmonary pressure that ruptures the parenchyma is a transpulmonary pressure of 35 centimeters of water, which is really it's not that easy to reach that level of transpulmonary pressure. So if you don't have transpulmonary pressure, you can really use the same strategy of protective ventilation also in the patient with COPD. I also prefer to monitor with another strategy, more advanced strategy, that being esophageal pressure. I would like to use impedance tomography. We don't have that, but it's a real useful for those subgroups of patients. COPD is a great example how these bedside tools that we use in the daily practice might not be enough.
Thanks so much. So, the final point for discussion, Dr. Ibarra, would you like to throw some light on mechanical power as a estimate, or as a parameter for assessing the ergotrauma that we are talking about nowadays? The energy that is transmitted through mechanical power and causing an injury to the lungs. Any comments on that? You said you're not very a big fan of mechanical power, but nonetheless, it is there now. It has evolved and it is coming up. So, any comments on mechanical power causing injury to the lungs?
No, of course, it's really an advantage. The identification, this tool allows you to detect all the process of ventilator-induced lung injury in an earlier phase, in the most early phase, there are no other measurements or variables that allow you to see the potential damage that you are inducing with the ventilator. It's really cool, but if you already know that you should use the less plateau pressure, the lower plateau pressure as possible, the lower tidal volume as possible, an adequate PEEP, the calculation of mechanical power doesn't really add nothing to your daily practice at the bedside. But the association with all the mechanisms we talk about in this presentation is really strong. The association of the level of mechanical power is really strong. But you should be aware, even Gattinoni himself, he says that it's not really the ultimate strategy to titrate ventilation.
Yes. Okay.
You know, it's just a pretty good combination of, and the correlation of all the variables you should pay attention. You know, but yes, the association, I don't really not aware of any studies in which a great association has not been shown. A good association with outcomes has not been shown. Mechanical power is always associated with outcomes.
Thank you so much. To my mind, the problem with mechanical power is one, whether PEEP is helpful or whether it's detrimental, because PEEP is a controversial thing. The other is the amount of energy that goes into the airways. That does not really damage the lungs. So there are controversies with mechanical power, but definitely it is helpful. So there are no questions from the audience. I think they have found it very helpful and very useful. So I thank Dr. Miguel Ibarra from all my heart and soul for sparing his time for all the young intensivists across the globe. And it's really wonderful to connect with South America, from Central America, Mexico, and have so many people joining us also. And it'll be there on our YouTube channel for everybody to view and to learn from this wonderful session that Dr. Ibarra has taken. Thank you so much, Dr. Ibarra. Bye-bye. Take care.
Thank you very much. My pleasure. Thank you. Stay well.